cause of mortality. But clearly, the absolute risk of mortality is holding constant at 1.0. And so it's not just about mortality, it's about the quality of life that people would enjoy during the time in which they're alive. So the question one becomes is what diseases are associated with reductions in what we call health-related quality of life? And the answer is that just about every known chronic disease that we can think about and add to those diseases which are not causes for our mortality, but definitely have a high rate of morbidity, including osteoporosis and arthritis. And all of them have a patient self-reported reduction in what they call quality of life. So I'll put to you a series of questions that were really framed by a physiologist named Frank Booth. That's Dr. Booth up at the top right there. And he said, what if there were a treatment that would lower risk and reduce symptom progression for all known chronic diseases, cancer, cardiovascular disease, stroke, type 2 diabetes, and on and on. He went on to say that this would work regardless of your age, your sex, your race, or your pre-existing risk profile. The good news is that actually we don't need to do a lot of research. It actually is a large evidence base on which to form recommendations. And it could save the healthcare system billions of dollars and yet cost comparatively little in return. I think probably from most people's perspective, and the one that I tend to urge is that the side effect profile, or what's known in pharmacology terms as the off-target profile of this treatment, includes a better prognosis for a variety of unrelated ailments, including depression, dementia, both all-cause and Alzheimer's related, self-efficacy, and even suicide incidents. And Dr. Booth framed it this way, that if it came in a pill, would you take it? And, it's probably not a great reveal to know that, of course, this is exercise. So just to give you some sort of framework for the definition of how physiologists and people in health research and epidemiology begin to describe not just exercise, but physical activity. So physical activity is defined as the movement of the body by skeletal muscle that results in energy expenditure. So this can be going for a walk, this can be gardening, this can be all kinds of things. Exercise, however, is the purposeful movement, if you like, of physical activity that's planned, structured, and repetitive, done with the main aim that you're improving physical fitness. And by physical fitness, it's not just aerobic fitness that you can see these two individuals on the bike here, but it's about musculoskeletal strength or fitness as well. So for older adults, in terms of physical activity, we have guidelines. And I think most people would be familiar with the physical activity guidelines. They're actually been recently revised in Canada to include what we call the 24-hour movement guidelines. So what do these guidelines say? I think most people would be able to sort of rhyme off 2.5 hours or 150 minutes of moderate to vigorous intensity aerobic activity. And it says to spread these activities out into sessions of 10 minutes or more. Now, the revised guidelines has actually dropped this duration down to even a minute or less. So that's with the recognition that doses of physical activity at higher intensities, for example, can have just as beneficial a consequence from a health standpoint as moderate intensity or low intensity physical activity. All of them, you tend to say that it is beneficial, and this is my own revision of that. I think essential to add muscle and bone strengthening activities with major muscle groups that will help your posture and balance. But the important take-homes here are that this is a dose response. And so flexibility and and balance exercises in this category also qualify. So what do we mean by a dose response? So I've tried to represent it for you here and really tried to make the case that people who are sedentary, who are doing very little, have a tremendous health benefit associated with the adoption of even a small amount of physical activity. So the biggest change in health benefit, or the greatest reduction in health risk, if you like, is always achieved when we take people who are doing very little or nothing to doing something. We get a smaller effect in people who are already active, and we get a smaller effect again if we take very active individuals. And clearly you can sort of see that at least schematically represented in this figure right here. So the question is physical activity one of the most viable foundations? And I'm just going to give you sort of, you're from McMaster, you have to talk about evidence-based answers to the question. So we're going to talk first about aerobic exercise and what we describe as cardiorespiratory fitness. And I think this is what most people associate the benefit of physical activity or exercise. And so, your heart performs better, your lungs are better at transferring oxygen. But I'm not sure that people realize that there actually is now an American Heart Association scientific statement and position stand that when we talk about vital signs, and so vital signs would obviously be respiration rate, blood pressure, heart rate, etc. The fifth, if you like, vital sign is actually cardiorespiratory fitness. And interestingly enough, as much stock as we put in assessments of things like blood pressure, blood glucose, blood lipids, etc., cardiorespiratory fitness is a stronger predictor of mortality than these established risk factors, even than smoking, high blood pressure, high cholesterol, and type 2 diabetes. And even if you took the addition of cardiorespiratory fitness to traditional risk factors, it significantly improves the reclassification of individuals with respect to adverse outcomes. And so we're talking about morbidity and premature mortality. In other words, if we had blood pressure, if we had heart rate, respiratory rate, and blood lipid panels, for example, or whether you had type 2 diabetes, if we add cardiorespiratory fitness, the classification of the person's risk for mortality or morbidity goes up substantially. And so I'm just going to give you some sort of evidence-based snapshots to help you understand how powerful physical activity or exercise is in some of the maybe less well appreciated areas. And the first one I'm going to talk about is obviously cancer. And I mean, here we have the leading cause of mortality, premature mortality in Canadian men and women. And this figure here, and there's going to be a lot of figures that sort of show you this thing, this type of graph, I should say. And this is a forest plot. And what it does is gives you the relative hazard ratio in this case, which is who will die, in other words, the soonest, relative to a control group for 26 leading causes of cancer mortality. And what's shown here is that people who have a greater leisure time physical activity participation, so this is not exercise, this is going for a walk, doing some gardening, getting your groceries, etc. What association with risk of mortality from cancer is reduced? And I'll just draw the line here and show you that 13 out of the 26 leading causes of cancer death are actually reduced in people who have a higher self-reported leisure time physical activity. Now, I think if, to put this in context, if this were a drug treatment for cancers as varied as liver, lung, kidney, intestine, we've got bladder and breast cancer here, this would be hailed as a medical breakthrough. So what about heart disease? And I think most people probably get the message that heart disease is still a leading cause of mortality. If we look to our neighbors in the United States, it's definitely number one there. But again, when we look at cardiorespiratory fitness as a predictor, you can see that greater cardiorespiratory fitness shifts the risk of heart disease, mortality from heart disease, such that it's protective by about 15 to 16%. Again, to put that in context, we get about a 5 to 7% reduction in risk from a standard statin, which is a cholesterol lowering drug, or about a 3 to 7% reduction in risk from an antihypertensive pill or medication. Well, what about diabetes? And I'm not sure whether people are familiar with type 2 diabetes, but it's it's 90% of diabetes cases. These are people who, we used to call it adult onset diabetes, but we gave up that name when basically children who were teenagers or adolescents were beginning to come down with type 2 diabetes. So this is not the failure of the pancreas to produce insulin, but it's a lack of response of other tissues in the body to insulin to allow those tissues to take up blood glucose. It's the leading cause of adult blindness. It's the leading cause of adult below-knee amputation, mainly because of the impact that continually high blood glucose has on those systems. And it's also the leading cause of the need for treatment with respect to kidney disease. Interestingly enough, again, you can see that cardiorespiratory fitness reduces the risk of premature mortality from type 2 diabetes. There is no, to date, medication that has the same degree of relative risk reduction in terms of mortality from type 2 diabetes. I'm going to now talk about dementia and Alzheimer's. And I think this is an area where people at least recognize that we probably have screened over I would say probably about 10,000 compounds in murine or mouse models. And then the number of compounds that have made it to human clinical trials is about 500. And I can tell you that today we probably have one or two medications that are designed to mitigate or slow the impact of either what we call mild cognitive impairment and development to advanced dementia or Alzheimer's related dementia. And so there really is no good drug treatment for what we're talking about here. And yet when we look at the impact of physical activity, you can see this is all-cause dementia and physical activity reduces the risk for all-cause dementia by about 13%. It doesn't seem like a great reduction. This is Alzheimer's related dementia and physical activity. And again, you've got a reduction in risk by about 8 to 12%. And that's a pretty substantial reduction in risk. There's also a slowing of progression of both all-cause and Alzheimer's related dementia in people who are more physically active. And even in individuals who have a high genetic risk or susceptibility, physical activity moderates the risk of these people progressing in terms of their dementia symptoms. When we look at this from a dose response perspective, and I think this is an interesting sort of figure, it shows you that the more leisure time physical activity that you spend, and we'll ignore the hours here, but think about 10 MET hours per week is really the basic physical activity dose. And this is about 50 minutes of physical activity a week or 10 minutes a day, 5 days a week. This is the advanced prescription. In other words, that this would be the 150 minutes per week, and we're down as low as 0.8, so a 20% reduction. And yet we can go to even further levels, and a reduction in relative risk of developing all-cause dementia now by almost 40% is if you came up with this and it were a drug, you would be winning a Nobel Prize. So again, this is an off target of what we call a side effect profile for exercise or physical activity. It's the same for Alzheimer's related dementia. This is 50 minutes a week. This is 150 minutes per week. And this is sort of an advanced dose, doing a little bit more. It probably involves about 3 hours per week of physical activity. But we know from self-report that most people don't even do 50 minutes. So we've got a lot of work to do. But just a quick summary of this part of my talk is that we have what we call evidence-based support. We've done systematic reviews, meta-analyses, and we can say definitively that we have a support for physical activity and higher fitness or cardiorespiratory fitness in lowering risk and improving prognosis, so progression of things like dementia, diabetes, and even heart disease for heart disease, cancers, type 2 diabetes, for dementia, and there even is an emerging area, although it's not, I think, as well established for depression. Well, most people would probably recognize that, aging, for example, is associated with a reduction in cardiorespiratory fitness. Activities of daily living take a little bit longer to do. They're harder for people to do. But there's a phenomenon that I'm going to describe for you with aging that we've given a name to that is known as sarcopenia. Now, probably, or maybe some people have heard about osteoporosis, and the precursor to osteoporosis is osteopenia. We know that people who have osteoporosis or a diagnosed reduction in their bone mineral density are at an increased risk for fracture. And the figure here is designed to show you somebody's leg when they are 20 years old, when they are about 50 years old, and when they are 70 to 80 years old. It's not actually anatomically probably proportional, but it gives you the concept that people as they age lose skeletal muscle. Now, when you lose skeletal muscle, we obviously know that you get a little bit weaker, but there are probably some under-recognized attributes that skeletal muscle has, in that it's the largest site of post-meal disposal and storage of blood sugar. So as your muscle mass goes down, the place in the reservoir that you have to store blood glucose is getting smaller and smaller. And this figure here is designed to, put across the point that muscle mass goes up, obviously, from the day we're born, and then declines, probably this inflection point's a little bit early here, but in earnest in people probably in their mid-fifth decade, so somewhere in their 40s. And you can see that the loss is, well, you can't see, but I'll tell you that it's about 1% per year for every year beyond age 50. Now, if people lost muscle like this all the time, this probably wouldn't be a big deal. But what happens is, even if people get into their sort of peak muscle mass years, there's a concept of a reduction in muscle mass that is more rapid. It's more rapid in people who do less physical activity, and particularly loading type physical activity, so resistance exercise or weightlifting. And the concept is that these people will hit this threshold in which disability is an increase it's not really a threshold as much, it's just an increase in relative risk. And I want to point out to you that this person here in yellow, we would call them a less successful ager, is hitting this disability threshold at around age 60. So the divergence actually seems small here, but it represents a substantial difference in somebody who is doing physical activity or being as physically active as they can, or participation in exercise, in that their risk for physical disability may only occur into their 80s. Obviously, this is an individual that we need to pay particular attention to. So what can offset muscle loss in aging? And the biggest thing is obviously physical activity. And this is just to make a point here. These are cross-sectional MRI scans of the thighs of I'll call them a 74-year-old sedentary individual. These individuals were exactly the same weight on a scale, so they had exactly the same body weight, but these are the thighs of a sedentary 74-year-old. And over here, we have a 70-year-old individual that is a triathlete, and that may represent the most beneficial adaptation. This is obviously a very active individual, and you can probably see that this is subcutaneous fat, and that there's sort of a marbling effect in here, and the muscle doesn't look near as good in terms of what we refer to as quality as this individual over here. But bear in mind that we could put both of these individuals on a scale, but when we look inside the legs of this 70-year-old individual versus this 74-year-old individual, this person is aging much more successfully than the other. So what does it really mean? Can we draw the same conclusions with respect to strength and muscle mass as we can for cardiorespiratory fitness? And these are data from what's known as the Inchianti study. This is an Italian cohort, and it's 5 years of follow-up after the age of initial entry into the study at age 75. And just to show you that this is the top quartile, the second quartile, the third quartile, and this is the lowest quartile. So the relative survival of these individuals over the ensuing 5 years of follow-up was the lowest in individuals who had the lowest leg strength. And this leg strength here may be not causally related, but it is a biomarker of survivability over the ensuing 5 years of follow-up. And you can see that there is sort of a staircase effect. And so really where you would like to be is in this top category, or the strongest category of individuals. So this is in men. And I just want to draw your attention to the scale here, down to from 1 to about 0.65. So this represents, a 35% loss in the lowest quartile here. And these are the data for women. I think you can all agree it doesn't look exactly like what it is in men, but it does highlight the point that where you really want to be is in the highest quartile compared to some of the lower quartiles. But leg strength in women is not as good a predictor of survivability over the ensuing 5 months, because this doesn't go down near as low as it does for men. So we're losing about 15% of our sample, but you can see that it drops off quickly in even the second, the third, and the lowest quartile of individuals. And so with equal sample sizes, women in the top are still getting a protective effect if they're stronger. I like to show these data because it's only in men, I'll admit that, but I like to say, and likely in women, have a reduced risk for both all-cause and cancer-related mortality. It doesn't really seem to predict things when you're younger than 60, but as you get older, being in the lowest 1/3 or the lowest 33%, your relative risk for mortality, both all-cause and cancer-related, goes up. And you can see that being in the strongest tertile or the upper 1/3 here is protective. And there are data that show that these trends persist across a number of different causes. So if we break all cause out into cancer, cardiovascular disease, type 2 diabetes related, Alzheimer's related, we get the same type of relationship. And I think that these are just traditionally sort of, I'll call them underappreciated or consequences of being physically active. We know, for example, that traditional risk factors like hypertension or high blood pressure elevates your risk for mortality. But again, to sort of make the point, if you're in the upper 1/3 in terms of your strength, and the same is true in people who are high fitness, so this combines greater strength as well as being cardiorespiratory fit, that you can see a reduction in relative risk for mortality, even in people who have high blood pressure. And these are risk ratios that look at the mortality risk being cut just about in half. And that's an impressive outcome, because even in people with controlled hypertension through medication, we can expect a reduction in mortality risk of somewhere in the neighborhood of 12%. But cutting mortality risk in half, and either if you have low fitness or if you have high fitness, is an astonishing outcome. I'd like to talk just a little bit about osteoporosis, because most people will, rightfully point out, well, mortality risk for osteoporosis is not that much elevated, but it greatly reduces people's ability to be physically mobile and mobile within their communities. So it's a tremendously disabling condition, and it's a very painful condition. So this is a laundry list, but you'll forgive me here, which is to say that exercisers have 1% less bone loss versus non-exercisers, and 1% doesn't seem like a big deal. But given that women postmenopausally lose about 0.7% of their bone every year postmenopause for about a decade, this is a substantial reduction in loss of bone. And people engaging in strength and aerobic activity had 3.2% less bone loss, particularly at the spine and the hip. And the result is that the rate of fractures in people who engage regularly in physical activity is half that of individuals who do not. So I think it's a noteworthy characteristic, again, because when you compare these things to drugs that are out there, anti-resorptive agents, things that are propping up bone health, you can expect an effect. And just remember, we could get all the other side effect profiles in terms of reductions in cardiovascular disease risk, diabetes, et cetera. And this is one area in which the strengthening exercises or loading exercises or weightlifting is particularly efficacious. Knee osteoarthritis. This is a condition that probably affects, by most estimates, at least 60% of older individuals. This is the arthritic condition that describes the breakdown of connective tissue, particularly cartilaginous tissue in knees. We could talk about hip osteoarthritis, hand arthritis, et cetera, et cetera. But when we talk about the efficacy of strengthening or aerobic exercise on pain relief, interestingly enough, the most effective exercise amongst these three types is non-weight-bearing strengthening exercise. So this is an older individual in our facility who's pushing a weight, so she's not bearing her own weight while doing it with her legs. And the interesting part is when you go and look at the pooled, what we call effect size of pharmacological pain interventions, it's on par with exercise as it is for most over-the-counter or even prescribed pain medications for osteoarthritis. There's no statistically significant difference between the two. So there was a tremendous reduction in pain. It's about 60% with obviously medication, but it's on par with that you see with physical activity. And so this is a meta-epidemiological study, and it at least provides evidence that knee osteoarthritis pain, which is the obviously number one reported side effect that causes people to be disabled and have reductions in mobility from exercise, but it's comparable to oral analgesics or pain relieving medication. So again, bringing it back to an evidence-based summary, we have support for strength now in lowering risk of mortality, morbidity, and disease progression for cardiovascular disease, for cancer, for osteoporosis, osteoarthritis. That's an impressive laundry list for two forms of exercise, one of which could be as simple as just going out for a walk with as little as 10 minutes a day, 5 times a week. Strengthening exercise is a tougher proposition. It requires maybe a little bit of equipment. But if there's anything that we've learned in the last, I would say probably 2 or 3 decades, it's really about the minimal dose of physical activity or the minimal dose of strengthening that you need to do to manifest these type of effects. It's true, it's a dose response. 150 minutes is where we would like everybody to be. But one of the key messages that I want to get across to you today is that we begin to see effects with as little as 5 minutes of exercise a day. And when I say exercise, I should say 5 minutes of physical activity a day. So most people's cited barriers to not doing exercise is time. And I would definitely agree that, for people who are at school or working, who have kids, time becomes a premium. However, when we talk about older individuals, I think that there are more hours in their day. I don't want to say that they're not busy, in which they could find to try and do something around their physical activity. So the question is, what are we going to do about this? And so when we talk to people who are uninitiated with respect to exercise, these are some of the things that we talk to them about trying to do with respect to initiating physical activity. So for the uninitiated, the key and I think most important thing is to find an activity that you enjoy. If you don't want to go to the gym, walking is still free. Swimming, there are plenty of public, basically free hours at a number of locations across the city, and or cycling. The Sobe bikes in Hamilton have been a massive success story, for example. We make the point to people that minutes count. In other words, we shouldn't think of 150 minutes as the goal, just that your daily activity level starts. And we like to say it about 10 minutes at a time, and that every little bit helps. For older individuals, and the pandemic shone a bright light on this, is that active time can also be social time. I think most of you can appreciate that older individuals who are isolated or socially isolated from their peers or their friends experience a higher incidence of depression. It even hastens dementia. And in some individuals, there's the thought amongst geriatricians that it actually hastens premature mortality. So if you're the kind of person that likes to hang out with other people, we advise looking for group activities or classes in your community, or get with family and friends to be active with you. Getting a membership to a gym, finding a program, lifting weights, trying to get stronger, walking wherever you can. And so this includes, such inane activities. And I know it always seems trite to say, but you're going somewhere, parking a little bit further away from the door. It's always an odd display to me that people will circle around a parking lot in a shopping mall, for example, for up to 10 or 15 minutes to try and find a parking spot that's closer to the door of the mall, when they could probably find one that's a little bit further away, and it might take them 1, maybe 2 minutes tops to walk to the mall entrance. And this is an interesting one, and I've slotted this one in with basically a tip of the hat to my colleague and good friend, Dr. Martin Gabala, that has found that these stair snacks, he calls them, or exercise snacks, where you ascend a flight of stairs and you do it fairly vigorously. So obviously safely, hold the handle, the stair rail if you need to, whenever possible. Stair climbing, I'm sure, as most of you probably know, if you've done it either voluntarily or not, you've had to run up a flight of stairs, really gets your heart rate up pretty quickly. I could share with you that we compared the traditional moderate intensity, what we call continuous training, that is used in standard cardiac rehabilitation, with self-guided stair ascents, at least 5 a day. And we found in individuals who were told just to climb a flight of stairs 5 times a day, that they experienced the same type of benefits during cardiac rehabilitation as individuals who did not. And the last one would be something like carrying your groceries home or carrying your groceries to the car. So hopefully I've given you a little bit to think about what physical activity and exercise can do for older individuals. But I know what this group is really interested in. So the question becomes, what can technology do for older adults? How can we get older adults maybe to encourage them to engage in more physical activity, or support their engagement in physical activity? So there's plenty of reviews on this topic. What I want to say, however, is that there's been few success stories. So when we talk about using wearable sensors, we can budge the needle a little bit in terms of looking at individuals with neurodegenerative diseases. We can change a little bit in talking about detection and prevention in people with mild cognitive impairment. And finally, I think this is an interesting one, the use of virtual reality technology in functional mobility. This actually is a little bit of a success story. In other words, we have been able to achieve significant results. But there are clearly barriers to use of technology. And what those barriers are is, I think, really where people who are developing technologies to support older adults should be spending most of their time. Technology is great. It's great for younger individuals. They adopt it very, very quickly, but older individuals are much slower to change. So when we talk about the barriers to technology, we could talk about trying to understand the physical barriers to the use of technology. And this is an interesting review paper that looked at things like difficulty entering text, remembering what to do, a lack of knowledge for cell phones. It's the same with computers, similar with tablets and e-readers. And that's around the technology itself. So what can we do in those situations to try and facilitate engagement? Well, we need to build aids that are able to be held by hands that don't move as well as young hands. We need to have magnification capability that's easy to access so that older people can see what it is that they're using, and there needs to be support. Other barriers include, and this is from another review that I found quite interesting, are issues around privacy. There is a lack, if you like, of trust that privacy, or that modern technologies will protect the individual from breaches of their privacy. Older people in general believe that a paper record of their health, for example, uh, kept in a physician's office is much more unbreachable than their health records being stored on digital sources. And so this really speaks to the issue of trust. And finally, I think it's around social support as well, around creating a community of older individuals that are able to support each other in their use of technology and to offer each other advice. Importantly, during the creation of devices or programs, we need to engage users, the end users, in that process. It's not enough to simply create something. If you build it, will people use it? Will they come? It it needs to be developed in close consultation with end users. And so understanding, and this is sort of a design type philosophy around getting these individuals together to talk about what it means to actually develop something that would be used by the individual in the end. And I think, a few technologies that show a lot of promise when you look at them conceptually from the outside have failed because they did not engage the end user during the development of the technology itself. There are a number of other barriers, and I just want to give you, a few. And I use this example all the time, is that there is a common misconception that to reap the health benefits of exercise or physical activity, that it needs to be vigorous, intense, and draining. And that's not the case. I've made the point a number of times in the talk, but the biggest reduction in risk and the biggest benefit occurs when we take individuals that are doing little or little to nothing and get them to do something. Now, on an individual basis, this may not seem like a big deal, but I want you to imagine the case where if we were able to do this on a population level and reduce people's morbidity and mortality, premature mortality risk from a disease that's very common and is expected to be the next related tsunami, which is type 2 diabetes. If we could get individuals to walk as little as 10 minutes a day, 5 days a week, we could reduce the morbidity risk and the premature mortality risk from type 2 diabetes by its estimated about 30%. The cost savings associated with that is enormous. Type 2 diabetes, in terms of its risk for premature mortality, is not really the issue. The cost of treatment of type 2 diabetes, the cost of diabetic drugs, the reduction in renal function, so kidney function, the progression of type 2 diabetes towards dialysis and the need for dialysis units is enormous. The visual health issues, the circulatory health issues, the prevention of amputation, for example, has an enormous ramification. So we only need for the needle to budge a little bit for the system to experience massive changes. Another common barrier or misconception is that there is an exaggerated fear of the risks of physical activity. It may be true that if I were to ask somebody to march in place at a slow and steady pace for 30 minutes, that their sudden risk for death would be lower than if I asked someone to sprint for 10 seconds. However, if time is the number one barrier, we know that 10-second sprints going upstairs, not really a sprint, but ascending stairs in a rapid manner as safely as possible, has the same health benefits as 5 minutes of moderate intensity continuous exercise. But there's a dissonance that's still held out there that it's the exercise that will create the harm. The reality is we know exactly what will happen if individuals are inactive or they don't exercise. And the bigger picture answer is that the reduction in risk and some of the things I've told you during this talk are far more important than the risk of a sudden heart attack, for example. So I'm going to try and wrap things up by giving you, this is Ron Davis. Unfortunately, Ron, the former president of the American Medical Association, not a particularly successful agent. He succumbed to prostate cancer very early in his life, but this is a line that I use often. If exercise were a pill and it contained all the or if we had a pill that contained all the benefits of exercise, it would be the most widely prescribed drug in the world. This is because exercise doesn't just target your heart. It doesn't just target your lungs or your muscle or your bone. It targets everything. This is probably why indicators that rely on measurement of physical activity, like cardiorespiratory fitness, for example, are so important. It's a measure of fitness that crosses multiple organ systems: your brain, your heart, your lungs, your circulation, your muscles. If anything is weak in that chain, then it means you're going to see it with a reduction in cardiorespiratory fitness or in muscular strength. So a failure at any one of those points is going to be detected. It's almost embarrassing to talk about how good exercise is for you or how good being physically active is for you. In other words, if we added up all of the sum totality of the benefits, and I said we're going to compare this to the best we can do in terms of medical treatment, pills, whatever you want to say, there is nothing like it. So with that, I'd like to say thank you very much for taking the time. Hopefully I've convinced you of a few things and given you a little bit to think about. I apologize in advance for the lack of the technology piece at the end there. It's not what I do. I think it's very valuable. I think there's tremendous gains to be made, but I want to emphasize that we need to engage the end user in this whole process. So thank you.
Okay, thank you for the excellent talk. Now we are open for questions. You can either just unmute your mic or raise your hand or even type your question in chat. First question is always the hardest, so let me just break the ice. Oh, Dylan, please go ahead.
Yeah, I can start it off. Thanks, Stu, for that great talk. I think it's really relevant for this group, right? And I think you brought up a lot of good points with respect to integrating this like technology throughout all this. A number of different possible questions, but I'm gonna focus on one related to kind of some of the tips that you gave. You know, having activity that people enjoy, like that, it's always a big thing, right? I did some work in trying to find the most appropriate exercise, which I think we can do, but at the end of the day, the frustrating thing is that it doesn't really matter. If I can tell someone that they're more likely to improve strength and pain with this, but they hate doing it, it's meaningless. But on the same note, I wonder if you can speak a little bit to kind of the pain side of it with respect to the no pain, no gain sort of idea. And with respect to osteoarthritis, that's something that we deal with a lot, right? Is that people have pain and they don't want to move because of pain. And how that kind of fits into this, because there is something to be said about moving through pain, but how to manage that, or how to kind of you know, contextualize that for them.
Yeah, you know, it's a great question. I think it's, I mean, the top barrier when you talk to people, say with knee osteo or hip osteoarthritis, and we say, you know, we're going to get you to move more, and that's actually going to result in a reduction in your pain, comma, eventually. And what they say to us is, well, when I do more, I'm actually, I feel like I'm in more pain. And so the point that we make to them is, well, we're going to ask you to move in a manner that is hopefully not pain-inducing, but eventually you're going to have to, as you say, sort of move through pain a little bit. Bear with us, and you will experience a reduction. And I think you're not a believer until somebody goes through the process with you, and shows you that it works. But there are countless examples. I mean, probably the biggest and globally most well known is like the GLAD program, that is pretty low level movements, that has been shown time and time again to result in pain in individuals who, you know, the number one self-reported symptom that limits what they do is pain. So again, I gave you this sort of meta epidemiological answer, which is that you can take all the over-the-counter drugs that you want, and even prescribed drugs, and exercise is comparable in terms of its pain reduction. But there's probably a phase where uninitiated activity is going to actually maybe inflame the condition that you have to kind of move through. But the eventual trajectory is a downward, you know, a reduction in pain.
Yeah, thanks.
So my question is, you alluded to the risk caused by exercise. I'm a big believer of exercise, but you know, I am aware personally and with friends that people suffer from injury, overexertion, or even some extreme cases, death. So how important you feel like it is to customize, individualize exercise regime and adapted like over the course of aging?
Yeah, I think to the personalization effect, I mean, there's probably two drivers. The first is personal preference. What do people want to do? And so, you know, it's a losing game to say we're going to get you to do this. And as Dylan mentioned, you know, if somebody hates it, I don't like doing this, it's unlikely that they're going to continue to engage. But there's another level to your question that I think is important, and that is to tailor exercise prescriptions to what it is that people want in the end. The overexertion and the injury, I get it, you know, I want to say younger, but even older people overdo it every now and again. And the consequences are it's not beneficial. It's painful. So the old adage of no pain, no gain, but that's completely untrue. Is no pain is actually, as people get older, they should realize it's no pain, no pain, still gain. And so that there needs to be a progression in exercise, either changing the form of it, employing greater distances or higher intensities, so that the adaptation continues. And that's where some of the technology can really help, I think, to guide individuals away from, you know, a sort of a one-on-one or a center that you know, like PACE, for example. So I think to your point, you know, that's something that we can do a lot better job on with using technology and guiding individuals, you know, on their own. So I think that that's an important point, but customized to what it is that they like doing as well. So yeah, I think that's a really important point.
Yeah, actually, that's exactly what my next question is. Like, you know, there are a lot of fitness apps and also wearable sensors that can monitor your daily activity and all that. So in terms of you know, having a customized regime, like what do you see like the technology can, what kind of role they can play? And you mentioned lots of barrier for older adults to access technology. Like how can we help them to have better accessibility and as such, because not everyone can afford a personal trainer for sure.
Yeah.
So how can we kind of help them to sort of improve their condition over time using like with adequate amount and adequate types of exercise over time, with possibly inputs from wearables and other source of digital information?
Yeah, it's a good question. I mean, I think that when you know, just a quick survey in PACE is that about 80% of our members carry a smartphone. So, you know, they clearly have an access to a device that could support an app, et cetera. I think that the app development just needs to be made, like the barriers in terms of, say, simplicity and the support if people have questions needs to be made very, very simple. I think that one of the biggest things that you can address with older individuals is something that we call self-efficacy. And that's really an individual's ability to perceive that first they can use the app, second, if they have an issue, that it can be dealt with. But then once that they engage in whatever it is that they're doing, it's A, something that they like, and B, it's something that they can achieve progress in quite quickly. And so we can start with a fairly low barrier, but it needs to progress. And that can all be app driven. But again, older people talk about, at least the ones we talk to in our center, about having a community of users or learners, if you like, that would then be able. So and people of their own age demographic, they don't want to call tech support and talk to somebody who's younger. They would like to talk to somebody in their own age group who's probably having similar problems.
I think that's an excellent point. But do you see, like, from a policy or regulatory perspective? I mean, I like the analogy to pills and prescribing exercise, but it's not a practice you can get from your family doctor or things.
No.
Do you see down the road there's the potential to have that?
Well, in Ontario, kinesiology is a registered profession. It's regulated under the Health Professions Act. And so as a registered kinesiologist, you can prescribe exercise. And so there is a mechanism, at least in Ontario, to get a prescription, if you like, for exercise. So I think for regulatory reasons, because healthcare is controlled provincially, eventually you will see people who could give you an exercise prescription become part of a billable healthcare act in most provinces in Canada. So there will be a cadre of individuals that will be able to give you that prescription and maybe interface with an app, for example. But at present, you're right. A general, like a family physician or most physicians couldn't give you anything that was a prescription. And so that it's a skill set that, I mean, we try to teach our students here that they would graduate with and eventually be able to help individuals for sure.
Okay, great. Any other question from the audience? So if not, let's thank Dr. Phillips again for the great talk. And the recording will be made public on the sMAP website. Thank you,
right.
Stuart. I wonder
very
if
welcome.
you have just have 1 minute, you can stay behind. There's another
Sure.
thing I would like just to quickly check with you.
Yep.
Thanks.
Okay,
Steve.
thank you.
Yeah.
Have a nice weekend. Yeah, so what I want to check is that I don't know how much you're familiar with the sMAP Create program. So one of our training module is to have this sort of observership. So for students, especially with engineering background, to have the opportunity to observe healthcare providers kind of in their interaction with older adults. So because of the pandemic, accessing long-term home hospitals are extremely difficult. I wonder whether PACE have a mechanism like for students just to observe that, the process, like the type of rehab procedure that you provide to older adults.
Yeah, sure. I mean, all of our providers would either be registered kinesiologists or physiotherapists. So we don't have clinician, we don't have a physician here. So it would be on that level, but I don't see why not. That, like, we do it every day. So yeah, I'd be happy to help facilitate that if you'd like.
So if we're gonna put together something like that, like what kind of like requirements you have? Example, how many students can be there at a time? Do they need to sign some kind of non-disclosure, like from get consent from the older adult to be there? Things like that.
Yeah, I mean, so in the past, what we've done is we keep it fairly small. We don't want to, get overwhelm individuals, but so we've had 3 or 4 individuals at a time spend various periods of time with our staff, and just observe. We always ask the individual. It's not a consent form issue, but we always ask the individual, and they're very used to it. We have students in the center all the time, so it's not something that would be like, oh, who are these people? It would be, I don't think it would be an issue. So all we've asked is that individuals maybe do a little bit of sort of training about what the center involves, and then go from there.
I see. So who would be the best person for me to reach out to?
Well,
to make
why don't you
arrangement?
send me an email and I'll put you in touch with the people that the ones that really make the decisions, not just me.
Okay, that would be great.
Awesome.
So you guys are back full swing. Like no longer
Yeah,
issue about.
We're here. We're yeah, it's as normal as it's going to be, I think. So
Okay, good to hear that.
yeah,
Yeah, thank you so much for your time.
my
Really
pleasure.
appreciate the
My
talk.
pleasure. Yeah,
Okay.
you're most welcome. Take care.
Okay, bye.
Bye bye.